We're going to talk about pain management. I gave this talk at the AMDA meeting last year with 3 other people from Seattle, Virginia, and California. So thanks to them for their slides who I've incorporated into this talk. Our learning objectives are to optimally treat pain, apply evidence-based medical and alternative treatments, and acquire skills in the QAPI process on how to manage pain in long-term care. So I'll talk a little bit about the requirements for nursing home care and pain. So the prevalence of pain in long-term care is anywhere between 40 and 85%, so much larger than the general population. But only about 25% of them may be receiving treatment, and we'll talk a little bit more about why that might be. And a large number of long-term care patients are undertreated. And it's highly related to dementia, which makes it more challenging to evaluate pain. So pain is very subjective, and the most reliable indicator is self-report. It can occur even without a physical cause, and it's very individualized how people respond to pain. So question 1, which of the following statements is false? Patients with cognitive impairment underreport pain. Poor pain management negatively impacts nursing facility CMS quality star rating. The Color Scale pain assessment tool is the best option for patients with severe cognitive impairment. High prevalence of pain, according to the MDS, has been associated with better pain assessment and treatment care processes. And nursing home patients younger than 65 have higher risk of persistent pain. The answer is C. Yeah. So the color scale is not optimal for advanced dementia because it requires a lot of abstract thinking, and oftentimes that is gone. All the others are correct, and we'll talk a little bit more about all of them. So the various assessment tools that are available are the numeric rating scale, the visual analog scale, and the verbal descriptor scale, or pain thermometer, the FACES pain scale. These oftentimes are very abstract and are difficult for patients with dementia to give us. I find most helpful the one that is more objective. So this was developed by Michael Gloth, and it looks at patients' ability to do things such as talk on the phone or watch TV. And accordingly, you can then say, well, if the patient is still talking on the phone and rates their pain as 10 out of 10, it probably is not quite 10 out of 10. So this would take that piece out of the equation. And it's a 5-point scale, but you can double it for comparison with a 10-point scale. So with varying degrees of cognitive impairment, different scales have differing accuracies and reliabilities. So with severe cognitive impairment, the verbal rating scale has the best data, but it's not great either because cognitively impaired patients just don't do very well with communicating their pain. So behavioral cues to expand pain in elderly. In cognitively intact patients, there is more reporting of pain than in patients with cognitive impairment, and the more severe the impairment, the less of it is reported, because patients just cannot communicate it. Even if they're still verbal, sometimes they just don't know how to express it. So the pain assessment in advanced dementia is one rating scale that you can use for advanced dementia patients, and it looks at 5 different parameters, and breathing, facial expression, and so on, and has the best data. This is a website for geriatric pain assessment for staff and facilities, that they can get training on various rating scales and just improve their knowledge about pain management in long-term care. So factors associated with higher risk of pain is younger age, no cognitive impairment, moderate initial pain, diabetes, and short-term sniff stays. And that's because many times patients come in for short-term stays because of a hip replacement or knee replacement, and therefore they have more pain associated with that. Patients who are long-term stayers are more likely to have dementia, especially advanced dementia, and therefore that pain is underreported. But the star rating is definitely affected by pain ratings. So that's part of the quality measures that the facilities have to report. The star rating is made up of 3 components. The health inspections, which is the surveys that all nursing homes have to undergo each year, and more often when there is a report. And staffing, which is reported by the nursing home, as well as quality measures. And pain is part of the quality measures that are reported under the Medicare reporting requirements in the minimum data set. It's a 38-page document. Here is a copy. It's not so minimum, but it's better than minimum MDS-2, which was over 100 pages.
Okay.
And it records all kinds of different parameters about the patient. It includes the PHQ-9, the basic inventory of mental status. So those things are helpful for us. And if we have a question about a patient's depression or cognitive status, we can look at the MDS, which is recorded here in the nursing home in the electronic health record, because it has to be reported to Medicare. And we can pull that up and see what the patient's most recent one was. It is done within 5 days of admission, then at 2 weeks, at 1 month, and 3 months, and then yearly after that. So they have a 2-week grace period with that. So oftentimes it's 2 or 3 weeks before it is done when the patient gets here. Okay. And they don't do the cognitive and PHQ-9 screening on the very first one because, and I think that's a good thing, because the patient is still getting used to the new environment, and that might skew the results then. Yeah. But pain is one of the things that is being collected as part of the MDS, and we have to ask about pain for all of the patients, and there is a little bit different approach for short-term stayers compared to long-term stayers. But we ask all of the patients about frequency, the effect on function, and the intensity. If the patient is unable to tell us, either because of aphasia or dementia, then we do still have to report it, but then we just report that the patient is not able to tell us and why. Pain can cause disruptive behavior and behavioral problems in dementia, and more severe pain can lead to actually maybe less wandering, but more agitation and more aggression.
Delirium.
Exactly, and delirium, yeah. So staffing, it seems like the higher the staffing, the better the pain assessment. And sometimes in facilities that have a lot of staffing and who do a good pain assessment, they have higher rates of pain because we're asking the patients more about it. And that then is held against the facilities in the reporting because they score higher on the pain scores. That does not necessarily mean that it's a bad facility, you know. So that kind of skews the whole rating system. And the 5-star rating system is the best thing that we have at this point, but it's not the end-all and not all that reliable and all that good in identifying facilities that are good and not good for that reason. So better staffing is associated oftentimes with better pain control, but that does not get reflected in the MDS oftentimes. So factors that affect pain management include cultural and language barriers. Oftentimes dementia patients have very nonspecific symptoms. Then comorbidities, of course, increase the risk of pain. Oftentimes patients don't want to take opioids for fear of getting addicted to it. And just clarifying that is very helpful, and we'll talk a little bit more about that. Then high staff turnover leads to increased pain because it takes a while for a staff person to learn the patient and identify how they express their pain, and therefore high staff turnover oftentimes is linked to poor pain control. And then lack of education, so hopefully we can change that with some schooling. The CDC recommendations recommend to first use non-pharmacologic measures to treat pain, and we have used ice and heat before on our patients here, and other measures are supporting the position and so on. And then establishing a treatment goal, discussing with the patients the risks and realistic expectations, because oftentimes patients expect to get rid of the pain entirely, and that may not ever be the case. So just making it more realistic can be helpful. Starting with immediate release medications, and then later moving to extended release if necessary. Then if patients need higher doses of morphine equivalents, then we might need to do a contract and look at it and see what else can be done. If patients require high doses of morphine or opioids, then we might need to have naloxone at hand in case the patient does get an accidental overdose, so that can be treated. And also making sure that we do urine drug screens, not so much in the nursing home, but if you have any suspicion of diversion, then that would be an option to see if the patient is getting those pain medications. The combination with benzodiazepines is as an adjunct. They do help each other improve the pain control. However, it also increases the risk of respiratory depression, so that we have to be very careful in using benzos with opioids. But at the end of life, it is oftentimes used, and it can be very helpful in controlling pain. And in elderly, we don't usually use methadone or buprenorphine because it's metabolized so heavily in the liver in the CYP450 system. Yeah, we don't use benzos really at all. We shouldn't be using them. But many times patients are on them because they were started many years ago. And in the 1960s, that's all we really had. We didn't have the tricyclics and the SSRIs that treat anxiety. So many patients are still on benzos from then, or need benzos for other reasons. And then we just have to be very careful with opioids. But yes, optimal, we should not give benzos at all. There are much better drugs available now. Next question is, which opioid appears safe in kidney and liver failure?
Hydrocodone.
Okay.
Or,
yeah. And hydrocodone is okay too. But in kidney failure, it can accumulate.
Oh, yeah.
Yeah, so we'll talk more about that in a second. So the best medication management is to start off with acetaminophen, avoiding NSAIDs in the elderly, and COX-2 inhibitors, if necessary moving to opioids, but always think of topicals and injectables if possible to reduce the need for opioids. So this is a cutout from the Beers criteria, and all of the NSAIDs and the COX-2s are on the Beers list and should not be used in elderly. Prostaglandins are vasodilators, and NSAIDs and COX-2 are prostaglandin antagonists, so that causes vasoconstriction. And in an older person who has already atherosclerosis in the kidney, the heart, and the brain, you don't want to constrict what little opening there is available for perfusion. So many of my patients that received NSAIDs in the emergency room or by their orthopedic or rheumatologist come back to me in heart failure and renal failure when they return for their follow-up visits, because these specialties oftentimes were not aware of that. So be very careful. In very rare patients do I continue the NSAIDs if the patients have been on them and say that that's the only thing that works for their pain, and if it really works for them, then I just inform them about the risk, but may continue that depending on their risk profile. This study compared Tylenol, which is paracetamol in Europe, with diclofenac and showed no difference in outcomes. Renal risk, there's decreased excretion of potassium and sodium, therefore NSAIDs can cause abnormalities of electrolytes, increases blood pressure by causing vasoconstriction, and CHF exacerbation. So historically, in the 1990s, there was a big push toward better pain control. It was considered the fifth vital sign, and we were treating pain much more aggressively, especially with opioids. Because NSAIDs increase cardiac risks, we have been using opioids much more so, and have moved away from NSAIDs because it increases the risk of AFib, cardiovascular deaths, and CHF. So that led to a real dramatic increase in opioid use, and therefore also unintended overdose deaths from opioids. And most recently, and I don't have a graph for that, but drug-induced deaths have outpaced motor vehicle accidents. So there were 100,000 deaths since 1990 from opioid overdose, and the highest risk group is younger than our patients, but our patients are still at risk. And there's no evidence of long-term use on efficacy and improved function in chronic pain, which is what we oftentimes deal with our older adults. There are screening tools available for patients and families when we suspect that they might be at risk of abuse. So before we start giving them opioids, and maybe use one of these screening tools, and this is SOAP-PR, just one of them. You can just Google it and use it. And then the FDA also provides a training module for providers to get more knowledgeable about the use of opioids and alternative pain management modalities. There are drug monitoring programs in all states now, and they vary widely on how useful they are and if providers are required or not to look at them before prescribing opioids. The one in North Carolina that we had also gave a map of where patients filled their opioid prescriptions, and it was very nice that sometimes if you had a drug abuser, you could see the line along I-40 and I-95 where they filled the prescriptions in various different pharmacies. As part of the AGS, I've been pushing towards making a uniform system across all states, so that when patients cross the line to another state or their family members divert the prescriptions to other states, we still have access to that, because currently we don't. This study looked at the risk of opioids compared to NSAIDs and showed that it actually increased the risk of cardiovascular deaths compared to NSAIDs even. So opioids are not benign drugs. We've talked about the overdose potential, but also risk of cardiovascular events.
Do you have a mechanism?
We don't have a mechanism for that, yeah. Now, this was an observational study, but it was a well-done case-controlled study, so it was well done. They did some propensity score matching to make sure that patients matched in their comorbidities and their risks. The average age was 80, but they eliminated 92% of those patients, so I don't know how representative it is for our patients, and they did not include any nursing home patients. But I take away from that study that it just means that opioids are not benign drugs. So cardiovascular events are higher, coronary artery revascularization are higher in opioid users. GI tract bleeding of the lower GI tract are higher, and bowel obstruction, of course, because the risk of constipation, yeah. So also increased risk of fractures. Yeah, so adverse effects of pain medication. Tylenol is considered relatively safe. We just have to make sure that our patients are aware of over-the-counter medications that might contain Tylenol, and tell them about those, and to talk to you about using any of those before they buy them, when you put them on scheduled Tylenol, to reduce the risk of Tylenol toxicity. Then NSAIDs, of course, have the GI bleeding risk, renal and cardiovascular adverse events, and so do the COX-2 inhibitors. The difference between COX-2 and NSAIDs in terms of side effect profile is that in the first 6 months, COX-2 don't cause as much GI bleeding than NSAIDs, but after 6 months, the GI bleeding risk is the same as in NSAIDs. So there's not really any benefit of using the COX-2 over the NSAIDs, and they have the same toxicity for renal and cardiovascular events. Then opioids cause constipation, nausea and vomiting, dizziness, probably because of the vasodilation. They can lead to respiratory depression at higher doses, and CNS depression, particularly if we use more than the patient needs. So as long as the pain receptors gobble up all the opioid, the patient doesn't have any of the side effects. But then as the patient's pain improves, we need to also back down on the opioid. So an 85-year-old patient was admitted after a hip fracture and had received a hip screw in the hospital. She's now admitted to our facility, and an order for Vicodin was ordered 1 to 2 tabs every 4 hours, and she is touch-toe weight-bearing for 6 weeks while she's in your facility. The nurse calls that the patient is complaining of itching and nausea. What do you offer?
Any history of allergies?
No allergies. Mm-hmm.
And I hate to be Benadryl patient.
Right, yeah. Very anticholinergic, so Benadryl is not a good option for the itching.
How about the Tylenol?
Okay.
Tone it down one.
Yeah. So use Tylenol so that we can use less of the opioid. Yeah. That's a good idea. So what we're probably dealing with in this case is that the patient's pain has improved a few days after the operation, and we have not scaled back on her opioids yet.
Okay.
So then her pain receptors are not gobbling up all the opioid, and then there's more free-floating opioid in the bloodstream that's then causing the side effects such as nausea and itching. And I usually explain to my patients that we then need to just back down on the opioid, and most of my patients are very receptive to that and are gladly decreasing their use of narcotics. When they're not willing to, then I'm concerned about maybe abuse potential. So using Tylenol would be a great option to schedule Tylenol, either stop the Vicodin or go to PRN oxycodone in addition to the Tylenol, which does not have any Tylenol in it. Then NSAIDs can lead to non-union and delay fracture healing in a couple of studies, so that's not a good option to use in our patient after her hip fracture. So opioid side effects include what we commonly know, but also MI, bladder dysfunction, and sexual dysfunction. And talking to young men about their opioid use, bringing up the sexual dysfunction piece oftentimes convinces them to not use the opioids then. So that is a piece of argument that I encourage you to use. Not only does it decrease erection, but also decreases libido. There is definitely increased risk of fractures with opioids. So
Is that with the long-term use rather than short-term?
well, I don't know whether they differentiated between long-term or short-term use. But yeah, so it's more with 20 cumulative prescriptions. So it's probably getting worse with cumulative use, but I don't know if there's a cutoff after which it gets much higher. Then MI is definitely increased with opioids, erectile dysfunction, motor vehicle accidents increased. So now our 85-year-old patient is admitted from the hospital, who was admitted from the hospital. The nurse calls you that the patient is agitated and sundowning. What do you offer? What do you think might be going on?
So patient is getting really delirious. Probably
Exactly.
our pain is not well controlled, and that would be one reason.
Right, so the patient's delirium might be from the uncontrolled pain. Exactly. Yeah. So agitation can be in dementia can be a reason. Can be caused by uncontrolled pain. So using Tylenol has been found in this study to be very effective, 1 gram 3 times a day, in reducing the risk of agitation in dementia. And usually when I treat agitation in dementia, I start with Tylenol scheduled. If it's only a certain time of day, I oftentimes just limit the Tylenol to that time of day and see if it improves it sufficiently. If it helps some but is not enough, then I go to scheduled Tylenol 3 times a day. If that is not enough, but it has helped, then I might add some opioids because I think that it might be from pain. If it's not due to pain and my pain management does not control the agitation, then my next step is usually an SSRI because that has some data on controlling behavioral problems in dementia. And then I go down the list, and that's another topic entirely. So our patient now, the nurse calls with the following day and says that the labs that you had ordered yesterday showed dehydration with a creatinine of 1.7. Okay, IV fluids. How about oral fluids?
Oral fluids, yeah.
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 So definitely just push fluids.
Yeah.
And opioids are vasodilators, so you do need more fluids to increase that capacitance that you've created. But at the same time, it can also cause central nervous system depression, and patients may sleep more with the opioids, therefore don't have enough time to drink and to keep up with their fluid intake. So there are lots of reasons, but keep that in the back of your mind when your patient develops delirium. So our patient with a creatinine of 1.7 has some renal failure, so we have to renally adjust her medications. And that brings us back to the first question, which opioids can we use in renal failure? And morphine is usually our first line drug that we use in the elderly because it's usually pretty easily metabolized, it does not accumulate. However, if you have somebody with significant renal failure and have to treat them for long term with opioids, then morphine is not the first line. However, the metabolite of morphine, the M6G, that morphine 6-glucuronide that accumulates with renal failure, takes a while to accumulate and takes a while to cross the blood-brain barrier. So in short-term patients where I expect the pain management to be short-term, because like in this case, after a hip fracture, I would still use morphine. Because for several weeks we're okay. It would take quite a while for that to accumulate. And by that time you probably don't need any more narcotic. But if you have somebody with chronic renal disease that you have to treat long-term with opioids, then you want to move away from morphine, and you don't want to use codeine in patients with renal failure at all. We don't use codeine in our elderly patients at all. It's also on the Beers list, partly because all of our elderly patients have decreased renal function, but there's also a ceiling effect with codeine beyond which you cannot go. And it's more constipating than any of the others. We use codeine quite a bit for cough. However, dextromethorphan is the stereoisomer of codeine and works just as well for cough as does codeine, without the side effects of constipation and respiratory depression and CNS alteration. So dextromethorphan is a good option for cough. So hydromorphone, which was your choice, is okay to use, but you've got to be very careful because it can increase or accumulate with renal function, with hepatic failure. Oxycodone is usually the next best choice that we use after morphine, and it's orally available. However, you also have to be careful with with hepatic failure. Codeine we don't want to use at all, and methadone is okay in patients with renal failure, but in hepatic failure, do not use it. It's highly CYP50 metabolized. We don't use it very often in the elderly because of decreased hepatic function as we get older. So fentanyl is the best choice in a patient with hepatic and renal failure. We don't use it as much in the elderly because the skin is so wrinkly that oftentimes contact is not that great, and the subcutaneous fat is oftentimes disappeared in our elderly patients, so they don't absorb as much of it. I still use it on occasion, and I try it and see if it works on the patient. If it doesn't work, then I try something else, maybe a long-acting oxycodone or morphine. So I try it and see what happens. Just make sure you always follow up on patients. This is an app, the Global RPH, that allows you to calculate opioid conversions if you're trying to move from one to another. Hippocrates also has a table in it. So the answer to the question was to use fentanyl in patients with hepatic and renal failure and liver, hepatic and renal failure. So orthopedics has established some guidelines for patients with a hip fracture, and they recommend multimodal analgesia treatment. So we have used, topicals like Lidoderm and lidocaine cream. Salonpas, which is a topical NSAID, would be an option. And we don't have data on fracture healing with topical NSAIDs. So that is not usually a first-line choice that I use in patients after a hip fracture. But ice and heat can be helpful with that. Also positioning. The other things for hip fracture treatment are osteoporosis treatment. And sadly, our patients still come from orthopedics, usually without a prescription for bisphosphonate or other medications for their osteoporosis, and oftentimes are put on vitamin D and calcium. But hopefully that will change with these guideline recommendations that came out in 2014. They do recommend intensive PT, which our patients usually get here in the facility, and also venous thromboembolism prophylaxis. And the chest guidelines recommend warfarin or enoxaparin for up to 35 days. And there's increasingly more protection up to 35 days, and then it drops off. So I encourage my patients to be on it for 35 days. Tramadol is a relatively new drug that attaches to the mu receptor, similar to opioids, but has a little bit different mechanism and was thought not to be as addictive. It also has the mechanism of an SNRI, so it helps with chronic pain in a different mechanism. But I don't like using tramadol because of the risk of hypoglycemia, even in patients without diabetes. And particularly in older patients, the risk is higher than in younger patients. And tramadol seems to be accumulating over time as well. It seems to look very similar to propoxyphene that we used to use, and that also accumulated over time and then caused delirium several weeks after initiation of the drug, which can be quite deceptive because at that point then you're not looking at tramadol because the patient's been on it for a while. But in my experience, and I've asked some other people in the audience over the years, that they have experienced the same thing. So I encourage you to be very careful with tramadol if you do choose to use it. QT prolongation has been in the news in the last few years, and higher doses of methadone and oxycodone, particularly over 100 milligrams of oxycodone, can prolong the QT. There is no QT prolongation for morphine or tramadol. But then we don't really know the long-term effects of QT prolongation. Does it really increase mortality? So what can we do? We can use topicals. SNRIs can be used for chronic pain management. Gabapentin at low doses, again, in the elderly, because gabapentin is highly renally cleared, you want to limit the dose to about 100 milligrams at bedtime. At higher doses, you see a dramatic increase in ataxia, falls, and CNS side effects from gabapentin. And in my experience, higher doses usually do not improve pain control any more so than low doses. It either works at the low dose or it doesn't work at all.
What do you give for neuropathic pain then?
For neuropathic pain, I usually like using SNRIs.
No.
So I start with Effexor, which is generic and fairly cheap. But I also have been using Cymbalta, which seems to be a little bit more effective and is also now generic, but a little bit more expensive than Effexor. Lyrica, similar to gabapentin, can cause CNS side effects and increase the risk of falls. Again, at low doses, I would try it. If the patient does improve with higher doses, just be very careful about falls risk and other side effects. If the patient has muscle cramps, try using calcium and magnesium. Do not use muscle relaxants, which are on the Beers list and can cause falls and CNS side effects. And I use quite a bit of injections, particularly if there's localized joint pain. Then I give a knee injection, shoulder injection, or any other joint as needed. And knee injections are safe. This study looked over 7 years at different frequencies of injections, and several patients received injections every month, and only one patient had an advancement of their osteoarthritis. But when you consider that it makes the patient mobile and keeps them from being bedbound, it's definitely worth it. And even if you need to inject them frequently, if they're not candidates for surgery, what do you have to lose? Hyaluronic acid injections, some studies have shown benefit, other studies have not. The latest review showed no benefit. I have also found no benefit in my practice. Steroid injection, which dose to use? I usually start with 40 milligrams of Kenalog, the lower dose. But if the patient does not have sustained relief from it, then I might go with a higher dose and see if it has more effect. But in most cases, 40 milligrams is sufficient. The AMDA clinical practice guidelines recommend repeat reevaluation of pain management. So after we have used something for their pain, reevaluate, try something else, reevaluate, try something else, or add something, take something away, and reevaluate. So in summary of medications, acetaminophen is first line, codeine not in older adults, fentanyl in renal and hepatic failure, tramadol can cause hypoglycemia, and delirium, exactly. And QT prolongation in high doses of oxycodone and methadone. So using non-medical modalities and non-systemic meds are really the best choice. So what can we do? We can use acupuncture, meditation, ice, heat, massage, osteopathic, manipulative therapy, and then therapy by OT and PT. Also look at the concept of total pain. Ask what the underlying issues are that might exacerbate the patient's pain. Maybe there is some family strife going on, maybe there's some depression. And then social pain and spiritual pain, particularly at the end of life, can be quite debilitating for a patient. So take a look at the whole picture and then try to treat it with non-pharmacologic measures. Oftentimes these non-pharmacologic measures are an afterthought and are not used very frequently in our patients and are also not documented oftentimes, even if we do use them. So if for spiritual pain, I would offer the patient some counseling, and depending on where the patient is with their religious beliefs or spirituality, I would either order chaplaincy or see if they have a priest or a rabbi or somebody from their own congregation that could come by. If they are non-religious, then maybe asking a psychologist to see if they would be interested in counseling with a social worker or a psychologist. And most facilities do have a psychologist that comes to the facility and provides that, but if that's not available, then sending the patient out for counseling might be a good idea. If the patient is hospice eligible, bringing the hospice chaplain or social worker in can be very helpful as well.
And that's in addition to Tylenol or any of the...
Exactly, yeah. You still use physical, medications if necessary, but oftentimes those don't have much of an effect on these other modalities of pain, such as spiritual pain and social pain. So why use alternative medications? We have limited evidence, and that's why we oftentimes don't use them. They oftentimes involve non-traditional practitioners, and we think of them as quackery or foo-foo. And our healthcare system does not usually pay for it because we still separate mind and body. And in our culture, we do as well. So which of the following non-pharmacologic interventions have the best supported evidence?
Oh, CBT?
Yes, cognitive behavioral therapy, correct. So the goal of non-pharmacologic measures is to modify the pain perception, reduce the intensity, increase tolerance, and improve the coping and self-regulation of pain. And then hopefully we can reduce the medication that we have to give. So physical modalities include PT, OT, can include ultrasound, TENS units, stretching, repositioning, exercise. Heat has 4 modalities. It can be conduction, convection, conversion, and radiation. And depending on the patient, one can be used over another. Use it anywhere from 5 to 30 minutes. Most of the time I use it at 20-minute intervals. And the temperature should be not above 45 to prevent burns. Don't use heat in patients who have ischemia because it increases the metabolic rate of the tissue. And if the patient has limited perfusion of the tissue, you could actually cause ischemia. So in patients with diabetes who usually have some vascular disease, peripheral vascular disease, be very careful. Also, patients with diabetes have neuropathy and oftentimes cannot feel if the temperature is too high. So they're at higher risk. Patients who have a hematoma or inflammation also would not benefit from the heat, and we might make things worse. With malignancy, that would increase the perfusion of that cancer. That would not be a good idea. And patients who cannot express their pain or perceive pain, who cannot communicate to us, it's also not a good idea to use heat. So cold can be used to reduce pain, also to reduce swelling and spasticity. Again, be careful with peripheral vascular disease because you're causing vasoconstriction of the blood vessels, and that might impair the perfusion. Patients who have Raynaud's, of course, would not be a good idea, and with cryoglobulinemia, but that is pretty rare, and patients who cannot communicate or sense. Acupuncture, there is more and more evidence coming out on the benefits of acupuncture for various types of pain, and of course it's very operator dependent. If you have a good acupuncturist, that can make all the difference. And if it doesn't work, when the patient goes to one, maybe going to another acupuncturist might help, but then it may not help either. So just trial and error is a good concept. Then others are meditation, spiritual counseling, hypnosis can be helpful, aromatherapy and herbal therapy. Again, the data on all these alternatives is not very strong, oftentimes only observational studies. Oftentimes, if they are randomized controlled trials, the sham methods are not good, or the number is very small in the patient population. But keep thinking of all these alternative things and try them out and see if it works. Music therapy can be very helpful, and imagery, positioning. We have dogs coming in for pet therapy here in the facility.
So, what is it? To just give a chance to pet the dog?
Right, and it just elevates the mood of patients significantly. Yeah. So think of psychosocial interventions, having the patient interact with others, and increasing coping strategies, social support, and treating comorbid depression with behavioral therapy. Then aromatherapy has some benefit, particularly short-term and in cancer patients and with anxiety. Relaxation can be very helpful. Can also really help with sleep problems, breathing deeply, and so on. And then meditation, mindful-based stress reduction can eliminate or alleviate pain.
So if you want patients to do this, who do we refer them to? Like there's no PAPT service, there's a service to do this?
Not in the facility here, but you could refer them out to various practitioners or see if they would come to the facility.
Okay.
Yeah. Then hypnosis, and not all patients are hypnotizable, especially with dementia, that might be a problem, but it's worth a try. There's more and more evidence showing of the benefit of hypnotherapy with labor and during childbirth, labor pain. Then imagery can be very powerful. And the best evidence is for cognitive behavioral therapy, just to put the pain into perspective and make the patient realize that it may not be totally controlled. Oftentimes helps. So in this study, cognitive behavioral therapy was effective and even sustained after 1 month of completion of the therapy. We really need long-term data still. So cognitive behavioral therapy has the best evidence. This is a review of alternative pain treatments of 28 randomized controlled trials of various interventions, 21 different interventions. 7 were no better than control. But, in individual patients, I encourage you to still use them and see if that patient has some benefit from it, and if not, try something else if you're up against the wall and you've already tried all the others. So CMS publicly reports quality measures for pain, and the facilities has to ask the question exactly like that. Have you had any pain or hurting at any time during the last 5 days? So it's very subjective, and it may not be very reliable in somebody with advanced dementia.
Yeah.
So these quality measures that are reported may or may not be reliable. And then writing down that it is almost constantly, frequently, occasionally, rarely, or unable to answer. And then the severity of pain needs to be recorded. There are some exclusions if the patient is unable to answer. Then we have to document why the patient is not able to answer. And the quality pain measure then does exclude patients who cannot give an answer, but does not include contribution of patient to the health state. So, in other words, if the patient has any use of narcotics, we still have to report that. It does include the patient's experience and is very subjective. The AMDA recommendation from pain measures is to recognize, assess, treat, monitor, and then look for clinical outcome measures. So this is a QAPI cycle, quality assurance and process improvement, that was done in one facility. They identified that they had very high rates of pain reported on their CMS, MDS quality reporting, and did a analysis. So on the MDS, it's subdivided into short-term stay residents and long-term stay residents, and in their short-term stay residents, they had a much higher than average reporting of pain, and looked at the root causes and identified that patients are admitted with as-needed pain medications, but they're not asking for it. So what they did in the facility, the problem was also that the staff did not give feedback to the practitioners to let them know that the patient is not getting the pain medication, is not asking for it. So what they did is they offered scheduled medications and wrote that the patient may refuse. And that improved their pain reporting dramatically when they reevaluated it, and it dropped their quality measure for pain in their long-term care patients and actually short-term patients as well. So in conclusion, identify the cause of pain and treat that, assess the pain using any scale, use non-medical approaches to pain control, start medical pain control with Tylenol and then use opioids as needed, and decrease the need as the pain improves, avoid NSAIDs and COX-2, and then reevaluate the pain and document it.